Good day, everyone, and welcome to Quality Conversations October 2024 Maiden Edition. It's a joy to be here and to be able to host this conversation open mic Q&A session where we'll look at all of the nuances that are the major nuances, not all actually, that are currently bothering our healthcare professionals. We are glad to be here today. This webinar should take about an hour. We are 5 minutes into the hour right now, and so we should have just a brief introduction, and then we'll delve straight into the questions that we've received before now. I'm here today with the amazing Kushbu Jariwala. It took me a long time to, what's your name again? Kushbu. It took quite a while for me to fix that in my brain, but hey, it's here now. And I'll allow her introduce herself. Over to you, Kushbu.
Yeah. So as Nene already introduced and said, my name is Khushbu Jariwala and I belong to India. However, I have recently moved to Austria, but throughout my career and academics, I have been part of Indian healthcare system. As she already mentioned, we met at ISHQA and we discussed so many things about the countries like us where there are many similar challenges that we encounter in the quality healthcare system compared to the western and other countries. And it is a pleasure to be here and I'm honored to be part of this conversation. So let's bring it in and let's share some more meaningful insight and let's learn from each other. So yeah, thank you so much.
All right, thank you very much, Kushbu. You are amazing. Thinking back at the conversation and how ISQA is International Society for Quality in Healthcare, and Kushbu and I met at the 2024 conference, which held in Istanbul, Turkey, in September. And I mean, it was an opportunity for us to forge meaningful relationships and understand in a cross-cultural, cross-contextual manner how healthcare improvement actually can how healthcare improvement can be deployed. So we've been able to transfer learning from one context to another. I shared some stuff, very few, and she and Dr. Brian were able to share a lot from their end, and we're able to just learn. And that, those conversations have majorly motivated me and inspired me to, push and press and keep going. Because if as I told them severally, if it can be done in India, that is in a similar context with us in Nigeria and with a very diverse population, and I mean, we bear a lot of similarities in our contexts. Large population, high population density. We have all of these races and multiple religions and castes and all of these things, and they are able to still work within this context to create improvements, remarkable improvements within their systems, and we can do it in Nigeria. We also have the same challenge of being resource constrained, and so I mean, we're basically able to transfer learning from one context to the other. So how Kushbu is not sharing today from a place, from a knowledge base of a resource abundant setting. So she's not speaking here, or we're not speaking today about things that are going to be far-fetched, difficult to achieve, or basically needing a lot of resources to implement. We are going to try to, we're exploring the questions that have been asked, and we are exploring providing solutions that are applicable to the context that we are. Most of the registered participants are in Africa and reside in Africa and work in Africa. And so we are able to apply the learnings into the context that we are, where we are operating. So nothing is going to be far-fetched, nothing is going to be above our heads. Everything is going to be within the resources that we currently have. I will be sharing my screen shortly, just to start off with the introduction, and then we'll go very quickly to the question and answer. Right. No, technology is not going to do this to me today. Okay, I think I'm just going to go normal if I can't find what I'm looking for. Okay. So I'm sharing right now, and I'm glad to say that this is QBS Global. I'm just going to confirm you can see my screen. I'm just going to give a brief introduction, and then we'll delve right in. So QBS Global, who we are Quality First Business Solutions Nigeria Limited. That is a registered organization name, and we are trading as QBS Global. We are a systems management consulting firm. We are dedicated to transforming Africa, especially the healthcare landscape. My passion is healthcare. Our desire, our goal is to see everyone starting from Nigeria and spreading out into Africa, across Africa, being able to access quality healthcare, achieve their desired health outcomes, actually see improvements in their health status without compromise, no matter, irrespective of the resources available to them. We are here to see that no matter the establishments, big, small, primary, tertiary, government funded, private, as long as healthcare services are being delivered, they will be delivered according to best practices. They will be delivered according to international best practices. The effectuation might not exactly mirror what is obtainable in resource abundant settings, but the requirements will be met, the standards will be attained. That is what we are aiming for. That is what we are working towards, assiduously working towards. Okay, so we are pardon this glitch here, we are leading the way in training, education, and implementation of effective management practices in Africa. We are, as I said, into management systems consulting. We train on ISO standards. We train on standards and certification. We also train on international healthcare accredited standards implementation. We audit healthcare facilities. We do gap analysis and help you to see what are the differences, where are we coming from, and all of these things. And these are some of the services that we provide. I'm going to just stop sharing right now. I just wanted to say who we are and what we do, and so that you can know who is speaking with you. I would not be able to start this conversation without significantly recognizing and honoring the memory of Janet Wasong, an amazing woman, a quality expert who was the founder of Quality First Business Solutions in South Africa, that launched in South Africa just before we started it in Nigeria. We went into a partnership that saw Quality First Business Solutions Nigeria Limited being birthed. And right now we are trading as QBS Global. Janet Wasong is now late. She's now of blessed memory. And who I am today and how far we have been able to come, I owe a lot of it. I owe a lot of my growth. I owe a lot of my understanding and knowledge base in consulting, especially, to her. We worked together for a long time, probably almost at different levels, probably almost all of my career in healthcare. Okay, in healthcare quality management, actually. So enough said. We're just going to go very quickly to the um quality conversations, and I'm going to be sharing my screen right away. All right. So Kushbu and I are going to be having this conversation, and we'll be sharing our thoughts. There's definitely going to be further room for questions, for asking clarifying questions, and we also will ask questions if we are not clear, and would request if per chance the person who asked the question is sitting in the room with us right now. So welcome. We asked from respondents, what is your biggest challenge regarding quality management implementation within your organization? And we had these answers. Okay, putting them together, we had these answers. Someone talked about consistency. Another person mentioned risk management. Another person mentioned document control, lack of manpower and resources, staff non-adherence to policy, understanding validations and post-calibration verification, point of care, and then how to bring everyone on board in implementation of quality. I'm going to allow Kushbu to start off. So Kushbu, when someone says that their biggest challenge regarding quality management is consistency, what recommendation would you give this individual? Well, how do you see this, and what recommendation would you give them?
Thank you so much for bringing this to me. First of all, I would like to congratulate the one who is facing the challenge of consistency, because it implies that at least they have started and they are on the way towards achievement of better quality and better healthcare for the patient. So congratulations and kudos to those people who have at least started the journey. Now, when it comes to consistency, there are so many theories talking about how sustenance is as important as anything else in the project, right? If we
Yeah.
take 5S quality management, which says about
Sorry,
salt,
Sorry, Kushbu. Let me cut you in briefly. Your video is turned off. Your camera is turned off. It was
yeah,
on a while
yeah,
ago. Yes, I think it's off now. Okay, fantastic. Yeah, back on. All right, go ahead. Sorry.
yeah. So we have learned from Kaizen and lean management theories. 5S are very important. The first S
Mm,
is sort, second is set in order, third is standardize, fourth is uh, standardize, and fifth is sustain. So sustenance is very, very important. Now, when it comes to consistency, so if, for example, if you have started one project in an organization, be it medication safety, what you can do is first step is to educate and empower people who are involved in the care management, direct patient care managers, for example, nurses, on-floor doctors,
mm.
consultants, physicians, and pharmacy team. After that, we can carry out continuous audits and monitoring tools based on the requirement. In the initial phase, we can monitor the same thing on a frequent basis, and gradually after achieving to certain level, we can reduce the frequency of audit and monitoring tool. However, it is the
Exactly.
fact, no matter where you are, uh, continuous monitoring and vigilance is very important. If the certain things are not monitored or not vigilant, even not on a frequent basis, it has the potential to lose, and deviate themselves from the path. So the
Mm.
only way to remain consistent is, first is vigilance and monitoring, and second thing is motivation and morale of the employees. You might conduct periodic audit, but it should not, demoralize the staff who's those who are not complying. So we need to continuously engage and involve the caregivers and motivate them, and maintain their morale. So yeah, it's all about giving them a purpose to, adhere to certain protocols and parameters.
Yeah, fantastic. Thank you so much for that. Indeed, one has to look at these things when there's a problem, there's a challenge with consistency. There can be several underlying factors. And like Kushbu has said, sometimes it's just the motivation. Why exactly are we doing this? Sometimes it is because the vision has not been clearly articulated to the people who are within the system. So why are we stressing? Why do we have to print? Why do we have to keep these records? You see, sometimes you that vision has to actually be communicated clearly. It has to be it has to be sold. We have to get the team members to understand and buy in. Now, everybody would not buy into the reason or the rationale or the vision of the organization or of the quality management drive immediately. But as long as you have your early adopters, you can have your quality champions, you have your early adopters, you just run with them and keep trying to use those early adopters and the quality champions to drive this into the system. And like Kushbu said, you build a culture and work with the employee motivation. Okay, so consistency, yes, can be a significant challenge, uh, uh, and which can be coming from different angles. But looking at it from the human side, no, understanding that quality management is not being done by machines. It's not being done by AI. It's being done by the people. So the biggest influencer of inconsistency or the biggest contributor to inconsistency and the quality management implementation drive would definitely be the people. They are the biggest factor. And so if you're able to get the people in and help them to think about quality and help them to buy into and sit into the implementation of the quality management as a system and as practices and as daily work ethics, then consistency will gradually be built. Sometimes we feel like things are not being consistent because they are not being consistent really, but sometimes they're actually making progress. And if we're not tracking the progress being made, you have a tendency to feel like everybody, every time we're slipping back. Or sometimes the curve is not a total, it might not necessarily be a steep curve upwards. It will be just like organizational growth in in um in in upward facing let me call them sine wave kind of curves. Okay, so you're having that, it's going up, it's going in those S curves. So it's going, there's a little bit of decline again, but it does go up a little bit. Yes, and then there's a little bit of decline. But if you track this change over time, you see that over 6 months, over 1 year, you are not where you were. You're not where you used to be. It might just feel like, oh, there's a lot of ups and downs, but truly you are not where you used to be if you're tracking the changes over time. Okay, so consistency, yes, is a problem. If we're able to work with the human side, we're able to work with the human beings who are responsible for implementing quality management, we'll be able to bring the consistency higher, be able to improve on consistency. But more importantly, let's make sure that what we are calling inconsistency is truly that, because sometimes it's just slow progression, and that change, that decline, that little decline, just when you're able to build an improvement or a new habit, can feel like, okay, there's that inconsistency. Thank you, Kushbu, for sharing. Let's move on to the next one. So the next one is talking about risk management. This is a 3-day course on its own. Excuse me. And so there's really not so much we can delve into here. But Kushbu, what would you say about risk management, just in like a minute, as a challenge? What recommendation would you give?
Based on my learning, whatever challenges we are discussing, whatever the answers are given, or whatever initiatives we take in terms of quality improvement, ultimately everything is narrowed down to patient safety. So if we are lacking any motivation, or if we are finding it difficult to share the vision to the ground level staff, or to explain to someone who is completely from the different healthcare system, we have to link everything to the patient safety. What if this is not done, and how it can affect the patient's safety, to what level it can affect the patient safety, and what could be the consequences of the patient safety that is compromised. So risk management is one of the ways how we can calculate the risk that it causes to patient safety. So it could be any risk related to clinical risk, infrastructural
Mm-hmm.
risk,
Mm-hmm.
or errors. So we need to identify certain areas, every department, vertically and horizontally both. Vertically by means throughout the facility, throughout the infrastructure, and horizontally means department wise, a nursing department as well as pediatric department, gynec department, general
Mm-hmm.
medicine. We need to identify the risk factors that can harm the patient, that has the potential to harm the
Mm-hmm.
patient and their safety. For example, it could be any furniture that is broken, it could be electrical loose socket, it could be not segregated biomedical waste. Now,
Mm-hmm.
to what extent it can harm the patient and the care providers, then we need to calculate the consequences based on that, and then we can prioritize the level of risk, if it is high risk, if it is moderate risk, or if it is low risk. If the certain parameters are falling in high risk, then we need to address it on an immediate basis, and if they are
Mm-hmm.
on lower risk, we can prioritize them on a later basis, because we cannot
Mm-hmm.
address all the issues in one go. So we definitely need to
Mm-hmm.
prioritize. So risk management is a
Mm-hmm.
framework, it's a matrix that provides us a clear vision how to prioritize certain tasks that can benefit the patient the most, and reduce the harm.
Mm.
So there are many tools available. For example, HERA, hazard identification and risk assessment. There is another one,
Mm-hmm.
FMEA, failure mode effect
Mm-hmm.
analysis.
Yeah.
So each tool provides us a different framework, and those have really good benefits and outcomes if done thoroughly
Mm.
and implemented properly.
Yeah. Awesome. Thank you so much, Kushbu. Indeed. Um, Yeah, I don't think I have anything to add to that. That is basically what it is. So you have risk management. You just have to set out a plan. Know what you want to. I mean, identify your risk. You have to start by, if risk management is indeed a challenge, the question will be, what have you started? What have you is it challenge in planning, challenge in managing, challenge in scoring or evaluating the risks, or where exactly is the challenge? But whatever it is, I mean, if you're able to leverage or get on the right tools for the points that you are in, you'll be able to solve the problem. Very well done. Okay, the next one is talking about document control. This one is yeah, I want Kushbu to tell me. I'll talk about it just for like a minute, but I want Kushbu to share how I mean, based on your experience before you moved over to Austria, how this was able to be managed in India while you were working in India, just so that we can relate with the brilliant improvement strategies that were implemented there. Document control, it's really not a very difficult thing. There are different levels, and sometimes people aim for full automation, paperless, and while that is very, very good in itself, you we don't want to get bogged down or being unable to take any action because we are striving for the best or most, you know, preferable system, right? So once we understand, document control is as simple as, what do you do? Do you have it written down how you do what you do? And where is the evidence that you have done what you said you would do? That is basically the general overview of what document control seeks to cover. And so if that is being a challenge, if an organization is facing that as a significant challenge, document control, it will be very necessary to start by saying, what have we recorded? Have we recorded what we are doing yet? Where exactly is our challenge? Is it on what we are doing, writing out what we are planning to do, and then benchmarking it against best practices? Or is it keeping records of what we have done so that we can, during reviews, we can look back and use data to identify where we need to improve on our systems? Well, Kushbu, can you share briefly, how document control, what challenges have you seen or experienced, and very, very succinctly, what improvement strategies were implemented to overcome them?
Yeah, sure. So let's keep our focus aside from a healthcare system for 1 minute, and let's focus on currency. Every country has a different currency, right?
Mm,
And every country's currency is regulated by the federal ministry or reserve bank of the particular country.
mm-hmm,
Now, it is hardly possible, or it is nearly impossible, that the citizens of the country are unaware of the running currency in the market,
mm-hmm,
which dominators are in the market and which are not,
mm-hmm,
the lowest one and the highest one.
mm-hmm,
On one fine night, or by any particular changes in the law or the regulations in government, the government decides to withdraw a certain denomination of the currency. For example, hundreds denomination or thousands denominations are withdrawn from the system or from the market. On the very next day, people will rush to the bank to exchange the currency, whatever they are holding.
mm-hmm,
Now, the bank will replenish the currencies and they will exchange and they will provide them the new or whatever is the recurrent currency in the exchange of whatever they are giving, which is obsolete as of now.
mm-hmm,
Now, to the surprise, how quick it is that people are adapting on the very next day and getting this thing exchanged. If we see the awareness of this particular thing, it is so rapid, so fast. And when it comes to our healthcare system or in the office where we try to change a certain document, it
mm,
takes us months and months to create at least an awareness, right? So why is it so? So it is just a matter of priority and the significance of it. So what, in my experience, what challenges I faced when it came to document control? Generally, document control is initiated from the quality team or from the administration department.
okay.
Now, what happens? They have studied all the documents thoroughly. They feel the necessity of modifying certain document based on the medical national guidelines or revision in the policies or requirements from certain accreditation bodies, like for example certain parameters are to be mentioned. For example, post discharge care needs to be mentioned in the discharge
Yeah,
summary.
yeah.
Medicine reconciliation needs to be documented properly. No doubt you are documenting it right now, but we need to modify it to make it more
Mm,
clear and to
mm,
improve compliance.
mm,
Now, what happens? This strategy and every modification is done in the administration office. On the very next day, they decide to call up a town hall or a meeting of staff, and they will pass on this information that we have made these changes. You will be provided the necessary training. Now, the training goes on for a couple of weeks. Almost all staff are covered in the meeting and the training part, and it is implemented. For certain days, this will be monitored, the compliance to the new forms and formats and new documents and new policies. Later on, people will not monitor it because they believe and they gain the sense of perception that
mm,
it is in the practice.
mm-hmm.
Now, what happens? I think in Asia or at least in India, people have that habit of hoarding certain things. One year later, we
Yeah.
see from the shelf that the bunch of obsolete documents is there, 1,000 copies,
Mm-hmm.
2,000 copies, which we were not aware. We decided to recall all the documents lying on the wards and different offices, and we gained also some of them, but we could not, cross match it with the existing stock. Now
Mm,
that stock is in the place. Now, what to do with it? Sometimes, without informing to the management, staff will start using that form.
Mm.
Now, through the audit or through the vigilance round, we will come to know how come this obsolete document is in the place.
Mm.
Then we will try to trace that loop, like where did it come from? The printing was revised and new forms were in the practice. How come this form, again in the system? Now we cannot blame one staff or one team for this mishap. But the ultimate culprit is the awareness and sensitization why we need to discard it in place of using it.
Mm-hmm.
Right. So recall process was carried out, but maybe it was not that effective that prevented this. Or the staff was trained on the new document, but they were not made aware of the significance of why we need to not use the previous one and strictly use this one. And the third factor could be why they were so afraid to at least discuss with the managers if they found these documents before making their decision to use it without any supervision or any permission or any approval. So these are the factors I think I have seen in my experience related to document control. So major
Mm.
policies are decided from the office, but when it comes to execution and the very first point, consistency and sustenance part, that is where we lack. It has multiple factors, it has many reasons, and it can be very different in different setups. Certain setups might have cost constraint that they don't want to waste old documents, so they might want to use it. Other institutions may have the awareness issue. Other might have communication gap between supervisors and the team. So these are the challenges that we face with when it comes to document control. But that is the one thing is very sure, the stronger your document control is, the better patient safety and the better staff satisfaction is.
Yeah.
If we carry out the document control activity on a frequent basis and on a regular intervals, we get the feedback from the staff, whatever is needed, what needs modification. Maybe there are some space constraint in certain documents, or they are finding it difficult to note down, so they will not write it instead. So consistently feedback, continuous feedback seeking and improving is the best thing we can do to reduce the burden to the staff and improve the patient safety. That is my view on document control.
Awesome. 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 Thank you so much for sharing. I like the analogy of money, and it really drives it really comes home to us here in Nigeria because that was last year, I believe. Yes, where there was the decision to change the currency, exactly like you said. And everybody run around and I'm sure maybe must have made the news in the international news. And just last week or early this week, it just came up briefly in the headlines again that they did not the XYZ notes for this particular tenders are going to be invalid by December 31. And there was you could feel the panic, like, oh no. But yes, when it comes to document control that has been since been rescinded anyway, just to clear the air. CBN has said no, that there's still legal tender beyond December 31st. But that really drives home the point that when it's money, like when it's your value, you are like, no, you want to change it, don't worry, I'm ahead of you. Before you change it and make the one in my hand useless, I'm going to make sure you change it. When it comes to documents that we use, so yeah, totally, it's important that the people understand why that those documents have to be replaced. And actually those who drive the system also have to understand the perceptions and the natural inclinations of the people within the system. Sometimes it might even be within a particular unit, and maybe in that unit they are used to, maybe the supervisor is maybe very hands not hands-on, but that's not the right word, um very bearing, person who just, so if I've not authorized for you to destroy it, don't destroy it. Even when a new one has been put up on the server or a new one has been, delivered to the department. And so you have people being just weary of touching anything or disrupting the status quo for whatever reason. So we have that as a real thing. Thank you very much. Yeah, Kushbu. Okay, can we just take the other two, because now we're coming close to time. And can we take lack of manpower and resources and staff non-adherence together, as well as how to bring everybody on board in mention of quality? Can you, more or less give a brief overview of touching these three aspects together, more like a tripod, and see how we can give a recommendation to somebody so that we can go to the other section that has fewer questions and see what we can do in about 10 minutes or 15 minutes on that side. All right, Kushbu, over to you.
So if we talk about lack of manpower and resources, I believe it's a global challenge. Many a times we feel that we are the only country or we are the only organization that has, high turnover of the staff, or we are not able to meet with the requirement of the manpower or the resources. I think it's a global challenge. In every country and every organization, they are running some sort of manpower, be it nurses, be it doctors, physicians, or infrastructure related resources. Now, if we take the example of our house, whenever there is some kind of scarcity of the resources, be it pandemic, be it, climate, or be it any financial constraints, we try to manage with the existing resources. However, it does not mean that we compromise on the way of living, or at least we go on starvation, but we manage somehow. So that is how the manpower and other resources are also to be managed when it comes to organization. Now, with the available resources, we can make the best out of it. For example, if we have shortage of trained nursing power, then we can deploy in such a way that every shift and every ward has at least minimum trained nurses that can empower and educate other nursing staff, that can be buddy to them, that can be a friend to the other nursing staff. So this way we can create a pool, and based on those effects, we can at least improve our outcome. And when it comes to resources, no country or no organization is having plethora of resources or they don't have any challenge. Each organization has some or the other challenges. We can always optimize it based on the need and necessity of it. So that is very much contextual and it is very much specific. So there is no particular answer to it, but whatever we have to make the best out of it and focus on those strategies that we can optimize the resource utilization.
Sorry. All right. Thank you. I was hoping that you would loop these three issues of personnel, the staff non-adherence, and the how to bring, and the last one, how to bring everyone on board alongside this very valuable position that you've put forward.
Yeah. So as we always talk, quality improvement is a journey and quality is a culture. So to establish a culture, it is not one person or one team job. It is collective. If there is a celebration of a festival in our houses, we all come together and we do some decoration, we do some rituals together, we share the responsibilities and we celebrate it together. The same way culture is built in an organization by collectiveness. Now, how to bring everyone on board in implementation of quality? In my opinion, shared responsibility is the best way to ensure compliances. For example, we talked about risk management, and I shared multiple views on there are many tools available of risk management. Now, if we say who knows the child better than the mother, right? So every department has their own staff working on it. For example, pediatric department will have certain staff working in that particular department. No one knows that department better than those staff. So definitely the risk factors of those department are known by that staff only, not by the external body. So if I am being an external person, I go and audit and try to assess the risk individually, then it will not give me the exact picture of the particular risk. I need to onboard them, I need to discuss with them, and maybe I need to share the authority to them, like bring up the certain risk that you feel that can hamper our patient safety and can lead to any kind of errors or can be a potential risk to the patients. We see that each will bring up so many risks, and this activity they will do so enthusiastically because they will feel the sense of accountability and the ownership. So I think sharing and distribution ownership is the only and the best way to build a quality culture and ensure the compliances.
I absolutely agree with you. I have a client where he was speaking about this quality. Whole thing was just like, what are you coming to bring to us? Leave us alone. What is our boss wanting from us? No, 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 no. We're fine the way we are. But just delegating responsibilities across the team leaders and encouraging them to cascade it across the team and making everybody a champion of a particular thing. You be in charge of this particular SOP development. You be in charge of temperature control monitoring. You be in charge of this and that and this and that and the other. Everybody just so when somebody else is saying, oh no, we have to change we have to change this particular way of operation and move into a better, or here's the optimized version, or here is the internationally benchmarked practice for us to work with. You understand, because tomorrow you are the one who is going to be saying, hey, in this particular section, I have been trained. Now I know I have had to do research. I'm responsible for this. And please, I need you to also make this adjustment. Yeah, so spot on. Thank you so, so much. I would probably have to do a separate conversation around understanding validations and point of care testing. I think we actually have a webinar already or maybe I'll just do another one or another recording on this, and then we'll share on this. This cannot be discussed or fully covered in a 1 hour long session. However, in summary, validations uh, are just what help you or provide you with the assurance that your equipment is performing to the required standards, they are doing what they are manufactured to do. If the car, let's say for example, a car is designed to run at a top speed or move at the top speed of 220 or a recommended speed of 120, and it's running at that operational efficiently recommended. We want to be sure that it is running at that operationally efficient defined limits. You cannot compare that to, or we have to say, if this equipment of this car was designed to run at this speed, then it should run at this speed. If it is a Formula One race car, it is designed to run at a different speed and it should run at that speed. So each equipment, what we are doing is testing, is the equipment before we begin to use it for patients, before we begin to work with unknowns, before we begin to use it to define the status on the state of health of any particular individual, bearing in mind that there are biological variations that would also come into play, which necessitates accuracy and precision in the results that are being delivered for each patient. We must first of all start, before we begin to run for unknowns, we must begin from the point of known. Performance specifications, performance characteristics and specifications, manufacturer specifications that have been outlined. Is the equipment before unknowns, is it operating at the point or to the degree that the manufacturer has said it will? There are templates, there are resources, there are tools to be used for this. And it's not about just running calibrations control and eyeballing it. It's about running it through validated tools and using them to establish a confidence level and also giving you something with which to pull forth any uncertainty of measurements in the future where any result is being challenged. This applies to a lesser degree, but very applicable also to point of care testing and equipment. For the next 10 minutes, I know we've talked a little bit about, so I've covered, we've covered risk management, we've covered document control, we've covered validations. Well, I've touched on it. And but we'll just spend the remaining 10 minutes talking about, we've also touched about sustaining quality when we talked about consistency and inconsistency, but we've not really talked much about patient safety and administrative support in implementation of QMS. But I would like us to spend maybe about 7 minutes talking about patient safety, because this to me is a very gnawing gap that needs to be filled, because it can be compromised in the slightest of manners, in the most unexpected manners. Patient safety can be compromised. This person asking to hear more about patient safety, really just when I saw that, I was just like, oh wow, that really warms my heart that you really want to know more about patient safety. Patient safety essentially, and I'm going to hand over to Kushbu, but let me just give a little bit of an intro. Patient safety basically is looking at ensuring that there is no compromise in the care of the patient throughout their time, or throughout end to end, from at every touch point within the healthcare system, that there is no compromise in their care. That is basically the summary of it. There is no compromise in their care. There is nothing that brings forward a risk of harm, that unintended harm, does not come to the patient at any of the touch points within the system. Patient safety is very robust and generally thrives on the effectiveness of the management, of the quality system, of the management system that has been built within the organization. It cannot be built in isolation, because it's quality management system or in operation within the organization forms the bedrock, forms the foundation, the framework, the guidance, the guideline, the guiding principles to how patient safety would be managed, will be maintained, will be planned for, because there has to be that point of planning for patient safety, right? And so it's an unending conversation. I mean, ISCO has been having the conversation about patient safety for what, 40 odd years, and we're still on the conversation. It definitely cannot be done in 7 minutes, but it is something that can be started. First of all, by thinking about who are our patients, identifying probably everything that, probably I should say everything that we've talked about already in this session, and pulling them together and using these to plan or provide a guide, provide a plan to keep our patients from harm, to keep everyone who comes within our system at every point looking broadly at we talked about risk, at every touch point where there is a risk for harm, for unintended harm to come to the patient, where there is a risk of misspell of the name, and then which can lead to wrong results, or exchange of results in the pathology section, or you're talking about wet areas or non or even the design, of the establishment, and does not provide for elderly people to be able to prevent falls in elderly people, or the design of the wards to prevent falls or to provide ease of movement by patients, and all of these different things, basically looking generally about every point of the system. I would come back after Kushpa has spoken with I mean, and I would and Kushba, I would like you to also provide a few takeaways. Let's say about 3 to 5 points that people can go with and begin to use to implement or to drive patient safety within their systems. Over to you, Kushbu.
If I have to talk about patient safety, I would like to narrate with one example. Imagine if we are going to a birthday party. There is a beautiful decoration. We are expecting a good celebration, to have fun, to wish our friend who is having a birthday, eat some cake, have some food, chit chat with friends, and go back home. Right. The similar scenario happens with the patient. For example, if a patient is at the hospital for an elective surgery, patient is having the imagination, currently I'm having the knee pain, but after surgery I will feel better, I'll be able to walk, I'll be able to do the activities that I was not able to do before. I'll be able to hang out with my friends. I I will be able to swim, I will be able to do cycling or to ride a motorcycle. So patient is having all these expectations when they come to the hospital. Now patient is in our hand. And many a times we become very happy when we go to birthday party because we receive the return gifts. So patient is also expecting a return gift of good health, a safe care, and a delightful experience. Now, return gift is in our hand. What kind of return gift we aim to give to the patient? So it could be very exceptional experience, the best quality of food, the personalized care, the excellent communication, the ambient room. But after the surgery, patient fell down. So does it even matter to them? No, because in the return gift, they always want a delightful experience. They don't want anything that is unwanted. So that is where the patient safety comes in. It is the reward or the return gift that we give to the patient. They should have a safe care. Ultimately, they are coming to seek the outcome. They want to get rid of the pain, they want to get rid of the discomfort, and they want to feel better. So, in addition to what we are offering to them, it should be always delightful and pleasant and not an error or discomfort. So that is the patient safety mean to me. If a patient is coming, it should not be needle stick injury. It should not be incorrect report dispatch. It should not be unsafe medication. It should not be incorrect medication. It should not be the incident of fall. And likewise. So patient safety is associated with each and every touch point, and each and every care provider shares the equal ownership and equal responsibility towards it. So ultimately, it's a collective outcome, and it is in our hand what kind of return gift we want to offer to the patient.
Awesome. Thank you so much. So identify what value add, how do you want your patient leaving your facility? That's what Kushbu is saying. How do you want your patient leaving your facility? What memory do you want them to have of their experience within your facility? Um, do you want it to aim? Let us aim for the most pleasant and the most beneficial experience, because if there's any compromise on their safety, it's more or less like taking care of a child. You realize that this child is can can do nothing without you, right? I mean, a baby, an infant. The safety and the care and everything about the infant is solely in your care, no matter who you are. And as long as you are responsible for that child, you are aiming to do all that you can to provide. So to provide the very best for the child, and to make sure that the child does not fall when you're putting the child to bed. You're checking, is there any risk of the child falling? Do I need to prop up this side? Do I need to raise the side of the cot? When you're going out on a walk, you're going to put the child in the trolley, and going to make sure that you're putting the belts across, because you don't want the child to fall. When the child is playing, you're constantly looking what risks are there. If the child is walking this way, is there a hole somewhere? Do I need to take the child away from this area for play? Do I need to cover something? Do I need to cover my sockets? What action do I need to take? And this is the same way we need to think about our patients. When we think about the patient is coming in, you who is a team member, you understand that, oh, there is a shaky tile or there is a loose tile somewhere along this corridor, and all of you instinctively know how to avoid the tile, but your patient does not know how to avoid that tile. So what are you going to do to prevent the patient from falling or from tripping or from being cut or from their shoes being destroyed by that loose tile? What action are you going to take, understanding that there is a risk of, let's say you have a new team member who is responsible for phlebotomy, for venipuncture, and is not, you understand that this person, probably has not had a lot of experience, is still undergoing training. Are you going to just leave the person unsupervised, understanding that there is a risk of, especially patients with difficult veins, how the new staff member, the new team member is going to, the proficiency is, or their expertise or their skill is not assured, and so you cannot leave them unsupervised. You have to think and say, hey, what is the risk if this person is left unsupervised, this person is left alone on a shift? What is going to happen to every patient that is going to need to have their blood samples collected? How safe, is there a risk of thrombosed veins, or what risks are there, and just looking at it and thinking ahead, basically just thinking ahead, as though you were that parent who is responsible for a particular child. So I would say patient safety is very broad. And the beautiful thing about patient safety is it's almost inexhaustible. Okay, you can't say, we're done. We finished doing everything about patient safety. Our patients are now safe. In fact, I promise you, the next day you will have an incident, because it's never ending. As long as people are coming every day, as long as things are changing, as long as there is natural depreciation, wear and tear, patient safety is. Oh, goodness me, so sorry about that. The network glitched. Okay, I hope you can still hear me. Thank you for being patient with me to come back in. All right, so here saying thank you very much. Thanks to Kushbu. Okay, she's dropped off. Thank you to Kushbu. And thanks to everyone for coming. We would look forward to hosting you again next month when we have another webinar. And we would make sure to send notification earlier this time around. We just need to get this off the ground, just so that we can get it done. As it said, just get it done. All right, please share with us your feedback. The link should have been shared. Has the link been shared yet in the chat? Please get the link from the chat. Thank you so much, Judith. And please, if you have any questions, just feel free to write back to us at qualityfirst.ng at qualityfirstng@gmail.com. Sorry, qualityfirstng@gmail.com. Can one of the team members drop the link, please, for feedback so that we can close out? So here's our email address. And then please leave us your feedback. Would like to know what you want to know more about so that it frames our next conversations. Who knows, your selected or your recommended copy or your recommended topic might just be what we take for the next session. All right, so just thank you. So let us know, and yeah, would keep in touch. Thank you so much. Here's the link. Please do well to fill it and give us your feedback, as well as let us know what else you'd like to hear from us. Thank you. Trudy, I see you. Thank you for coming. Right then. So thank you, everyone. Have a good evening from Nigeria. Bye-bye.